We're here for male reproductive. It's a very simple system. Most of the more interesting questions are affiliations with pathophysiology, BPH, baldness, but the direct function of male reproductive is very straightforward because there's no cycle. It's always going in the same direction. Male reproductive starts out in the hypothalamus like all the other things. And gonadotropin-releasing hormone makes LH and FSH, and LH and FSH makes testosterone and from the luteinizing hormone and follicle-stimulating hormone on the Sertoli cells. This is a straightforward system where you have LH making testosterone. Testosterone has feedback inhibition on the pituitary. Now, the only thing that's an extra here is that we have dihydrotestosterone. Now, dihydrotestosterone causes some extra functions of the penis, the prostate, and the scrotum in babies, male pattern hair loss in adults. Now, there's a different representation of the exact same thing I just said. So let's say it all again. Looks more colorful, doesn't it? It's like a slice of pie, isn't it? Yes, it is. A little slice of testicle. There you go. Now, the pituitary makes the luteinizing hormone, and the peptide hormone touches a surface receptor. The surface receptor activates the G protein. The G protein sends a second messenger, which in this case is cyclic AMP, and looks like the same machinery as in the adrenal gland, doesn't it? There is a reason it looks like the same machinery as in the adrenal gland, because it's the same machinery as in the adrenal gland. Except the gonads have extra enzymes. So the DHEA and androstenedione, which is the end product in the adrenal gland, go further in the testicle into testosterone. The testosterone stays in the testicle at a rate of 50-to-1 compared to the blood. The testosterone in the testicle has 50 times the concentration because we have androgen binding globulin. Now, there is a little bit of estrogen in Sertoli cells. You'll see that there's some aromatase down there that makes the estrogen. And that's why in testicular feminization, also known as androgen insensitivity syndrome, you still have breasts and the vagina because the Sertoli cells and adipose tissue make some estrogen. Now, if it wasn't for the Leydig cells making testosterone, the Sertoli cells could not survive. The Sertoli cells need the testosterone to be able to stay alive. Now, there's another substance there called inhibins. Inhibins are a substance that has no deficiency disease, no excess disease. Inhibins exclusively inhibit FSH. What a great name. They've never been developed therapeutically. They should have been developed as a form of contraception because they would only stop Sertoli cells. But they are just a disembodied fact. Inhibins are made, they stop FSH, and that's it. No deficiency, no excess, no therapeutic. So, Leydig cells make testosterone. Most of it stays inside the testicle. A small amount of it goes backwards and causes feedback inhibition and shuts off the luteinizing hormone. Now, there is 5-alpha reductase, which makes dihydrotestosterone out of testosterone. And that dihydrotestosterone is a form of it that just has a different effect in a fetus. The dihydrotestosterone makes the penis, the prostate, the scrotum, the penis, the prostate, the scrotum. And testosterone in a fetus makes the internal male structures, the vas deferens, the seminal vesicle, and the epididymis. So testosterone makes the internal male structure, and dihydrotestosterone makes the relatively external penis, prostate, scrotum, PPS. Dihydrotestosterone also makes men bald and BPH. But don't you find it intimidating that a fetus has as much testosterone as you do? I do. Hey, fetus, why you got as much testosterone as me?
You're not much of a man. I have as much testosterone as you.
Yeah, but you're cooped up inside a uterus, so you can't talk to me. Well, the fetus has as much testosterone as an adult man because it needs it to make the glands, makes the hormones, makes the structures, makes the machinery, the man machinery, man junk. Needs all that testosterone to make the package in there. Okay? FedExing the package into the fetus. And so therefore, the testosterone, again, internal male structures, epididymis, vas deferens, seminal vesicle. External male structures from dihydrotestosterone, penis, prostate, scrotum. Then it goes away at birth. Now, what at stage 3 in puberty makes it spurt up, I don't know. But what you notice here is that testosterone never goes below 50% of the lifetime maximum. So that's why a man can continue to have babies till he's 100. Because he continues to make testosterone. The fetus needs testosterone to make structures. But we also know that if we didn't have Mullerian inhibiting factor, wouldn't we all end up female? Yes, it's true. We're all born female. Now, the Mullerian inhibiting factor comes out of the testicle. And if there was no hormonal input from the Mullerian inhibiting factor, we would all end up female. So what we know is that the normal male development requires 3 things. Testosterone to make the internal male structures. Let's say it again. Vas deferens, seminal vesicle, epididymis. Dihydrotestosterone to make penis, prostate, scrotum. And Mullerian inhibiting factor stops the internal female structures. Well, fetal life also means that the Wolffian ducts differentiate into the male structures. Without testosterone, they'd go away. Epididymis, vas deferens, and seminal vesicle. And dihydrotestosterone in adult men make BPH, benign prostatic hypertrophy, because it makes a prostate in the fetus, and baldness. And remember, without Mullerian inhibiting factor, we'd all end up female. We start female, but then the testicle strikes back. It suppresses that femininity. So as soon as we're born, right after birth, LH and testosterone drop down to low levels and remains low until puberty. Why it bumps up then is not clear. But once the structures are made, we don't need all that LH. At puberty, what we see is the LH pulses become greater, and then it starts to go up, and then all of a sudden they start to secrete testosterone. So the mechanism for this is unknown, but then again, the mechanism for what starts delivery of babies is unknown too. What actually says it's time to start parturition? Not clear, not clear, not clear. In an adult male, the luteinizing hormone drives testosterone secretion. Well, I think we said that, right? We said that it looks like the machinery in the adrenal gland, except it's testosterone. Why? Because the gonads go further. They have a few more enzymes. And what ends up happening is that as we age, remember that the adult man, like 70 and 80, still has a lot of testosterone. Men in their 70s still go 2/3 as much testosterone as a man in their 20s. So don't believe them when they start showing you all these testosterone commercials on TV, telling you all have to need that. That's all a racket. Also remember, for an old guy, if he takes too much testosterone, ages his coronaries, burns his coronaries. Not good for an older guy, really. And there's no andropause. We may talk about andropause as a sociologic phenomenon where guys slow down and all of a sudden the testosterone goes down, and now you know it's all hormonal. Now you can understand your family better. Right? You like that. So but there's a sociologic andropause, but not a physiologic one. So androgens stimulate protein. They're anabolic. They decrease protein breakdown. They increase DNA polymerase. They increase mRNA. They increase protein production. That's why the ball players use it, because it makes muscle mass. And not only that, it also increases red cell productions. It's one of the things people don't understand. Androgens don't just make muscles big. They actually increase your hematocrit. It's kind of like saying that, I bought you a really big house, but I didn't give you any money to pay the electric bill or pay the taxes. What's the point in having really big muscles if you don't have erythropoietin, you don't have red cells to supply them with oxygen? And so the androgens taken by men and women both increase both of their muscle mass. They do. And they increase the red cell count as well. So making sperm is temperature dependent. That's why we have testicles, to keep them warm. I mean, basically testicles are like a flower, aren't they? They're like an orchid, like a beautiful flower. You wouldn't keep a flower in the hot, would you? Then it would wilt. But on the other hand, don't make it too cold because it'll wilt too. How do we know it's a flower? Well, what do you call it when you get an infected testicle? Well, it's your infected orchid, right? Orchitis. So infected orchid. And when you cut the testicle, you're cutting the flower. It's an orchidectomy. Orchiectomy. See? And it wilts. So they're temperature dependent, and therefore you have to lower the temperature a point or two below normal body temperature. And if you don't pull that nut out, it cooks, makes like popcorn. Okay? It pops into testicular cancer. That's why you got to pull it out. So you cool it, and then a couple degrees cooler, 1 to 4 degrees cooler. And that's also why it is that you can actually use scrotal refrigeration units to increase sperm production. Most people don't know that. They think I'm joking in class when I go, what do? You go, well, you actually have a scrotal refrigerator that increases sperm production. Like, ha, ha, ha. Yeah, but it's true. It's true. And if you don't pull a testicle out by a certain age, it turns into testicular cancer. So FSH stimulates Sertoli cells to nurse the sperm. Their Sertoli cells don't actually make the sperm. The same way if I sent you to an apartment to rent, the apartment didn't make you, but I mean it does nurse you and keeps you happy. And the Sertoli cells nurse it up so it can grow. And if you have undescended testicles, the FSH goes up because you're not having the normal feedback inhibition you should, and the pituitary starts to yell at your testicles. Hey, do some work, man, make something. So when you have a decrease in your testosterone production, it's the loss of feedback inhibition. And the loss of feedback inhibition increases LH secretion. That's understandable. Erection is a vascular phenomenon. And that's why it is that you can't use nitroglycerin directly, because nitroglycerin is a venous dilator. And a venous dilator alone will result in just as much blood out as in. That's why sildenafil, tadalafil, and all the other fills fill your penis, because they are arterial dilators and not venous ones, and one-way flow in. That's why nitric oxide works, because nitric oxide dilates arteries much more than veins. One-way flow in. So the sperm and the semen goes from the epididymis and the vas deferens and the seminal vesicles finally into the prostate. Did you know that prostaglandins were first described in the prostate? That's why they're called prostaglandin. And prostaglandins actually came out of the prostate so that it caused a rhythmic motion in the female fallopian tube to pull the sperm in. Kind of like, hurry up, honey, you're going to be late. Get over to the distal third of the fallopian tube. Oh, my God, he's late again. And that's why. Because prostaglandins help pull it in. It's kind of like calling to get sure people show up on time. So emission ends up being sympathetics and parasympathetics with erection. Parasympathetics for erection, sympathetics for emission, point and shoot. PNS, point and shoot. Now, the most common cause of erectile dysfunction post-myocardial infarction is actually not the beta blockers, it's anxiety. And the most common question for you to have is not to use nitrates with Viagra, with sildenafil, because they cause hypotension. That's the big question for you on this. So it's both sympathetic and somatic efferents that cause ejaculation, and striated muscles are somatic efferents from the central nervous system to make it go out. So it's mostly sympathetic and somatic. Sympathetic and somatics. SOS? Sympathetic and somatic. Low testosterone in the second and third month of gestation results in decreased production of internal male structures. And that is because you need testosterone to make the internal male structures. And remember, dihydrotestosterone comes out of the testosterone. So if you don't have the testosterone in utero, you don't make any of the male structures. See, it's different than just saying in the third trimester. If it's low in the third trimester, you can still make everything. It's just smaller and doesn't descend. You need the testosterone for the final stage. In puberty, the unicoid appearance means that you don't have facial hair, you don't have axillary hair, you don't have deepening of voice, and things just stay smooth and small. I mean, unicoid appearance is like a castrati from the 16th century in Europe. I've become a great opera singer. And post-pubertal is like that those people in your life, like your ex-boyfriend that you don't like, that never seem to have any real interest or drive for anything. Klinefelter's and Kalman syndrome are both forms of hypogonadism, and they are both forms when you don't make testosterone. Now, Klinefelter's, you have a lot of gonadotropins, you have the FSH and the LH, but nothing is produced. Kalman's is when you don't have the FSH or the LH, and nothing is produced. So the end result is the same, but Kalman's has a anosmia that goes with it that will help you recognize the case. Klinefelter's will be tall, XXY, and will have high FSH and LH. Kalman syndromes has a low FSH and LH, but both of them will look the same in terms of low testosterone production. So it seems like a busy slide, but you'll notice that everything except for giving some anabolic steroids, everything seems to be low on the sex hormones. So primary hypogonadism is like people who are postmenopausal. The target organ's not making anything, but the pituitary is stimulating FSH and LH, but nothing's coming out. It's rather like thyroid failure, too. TSH is up, but no T4. Now, when you have Kalman syndrome, the whole idea is that you have no gonadotropins at all, so you're not making sex hormones because you don't have gonadotropins. Look for anosmia. Postmenopausal women is like the thyroid failure. High TSH, but no hormone produced. Now, the main thing that I'm concerned about here is that you understand that the treatment for prostate cancer, gonadotropin-releasing hormone agonists, leuprolide, goserelin, neferilin, leuprolide, goserelin, neferilin, have to be given after the start of testosterone receptor antagonists. That's why I leave this very busy table on here, because it reminds us to say, if you don't give flutamide, icolutamide, and the other testosterone receptor antagonists first, and you start with a GnRH agonist, there'll be a big bump up in testosterone. And unless you block that testosterone, you will cause a growth of the prostate cancer. And the question they're going to show you is they're going to say, you got a guy with metastatic prostate cancer on his spine. What do you do first? And you're supposed to say flutamide, bicalutamide, testosterone receptor antagonists. Because the pulsatile administration of them, the bottom line, results in a big bump up in androgens, a big bump up in testosterone. So you'll first need to start testosterone receptor antagonist. Then you can start the GnRH agonist. Now, the last point for this section is not to confuse the 5-alpha reductase medications that you use for benign prostatic hypertrophy and baldness with testosterone blockers. I know very well from the last 23 years in class exactly where people make the mistake. It's very easy to screw this up, because 5-alpha reductase inhibitors, which is finasteride and dutasteride, sound an awful lot like the prazosin, doxazosin, terazosin, doxazosin, which is alpha adrenergic blockers. So those are BPH drugs. And what's weird about them? They all have the word alpha in them. But 5-alpha reductase blocks dihydrotestosterone. Alpha-1 antagonist opens the internal sphincter. However, what you need to do is a testosterone antagonist. Flutamide, bicalutamide, then GnRH agonist, because the GnRH agonist will bump up testosterone. Use the testosterone blocker first. See you in the next section.